Hi, my name is Ed Septimus. I'm in the Department of Population Medicine at Harvard Medical School. Its first presentation is entitled Involving Etiologies for Community-Acquired Pneumonia, or CAP. This is the causes of pneumonia in the pre-antibiotic era. So this was well before the 1940s. And as this slide indicates, the pneumococcus, or Streptococcus pneumoniae, is by far the most common organism back in the pre-antibiotic era. And you can see other streps and Klebsiella and staph, but predominantly it's the pneumococcus. As we move into the 1970s, the causative organisms are pretty much the same. We have better diagnostics. This was done through transtracheal aspirate or sputums. They were able to identify a bacterial cause in 88% of cases, with once again the pneumococcus predominating of 30%, but you see more of a smattering of Staph aureus, Klebsiella, other gram-negatives, and for the first time, a Haemophilus, making almost 30% of strains at that time. As we move into the beginning of this century, there were three very nice studies that were presented, one from the UK, one from Sweden, and one from Holland. And you can see if you look at this particular etiology, the pneumococcus still is an important etiology in all three studies, but two of these three studies began to introduce diagnostics for viruses. And as you can see in the boxes, 19 in the UK study and 29 in the Swedish study. They didn't use very sophisticated PCRs in the Holland study, but for the first time, we knew in pediatrics we saw lots of viruses that could cause pneumonia. But now for the first time, we begin to see that adults may also be an important source of causes for pneumonia. And you can see 48% for pneumococcus, 38% for pneumococcus in the Swedish study, and 37%, so pretty consistent across the board. And one of the things that we noticed in the Holland study, which did not use PCRs for sputums and nasopharyngeal, that 44% of the time they were unable to identify a pathogen. But in the other two studies, because they introduced viral PCRs, the number of no pathogens identified was greatly reduced. Then we go into the next decade, if you would, some very nice studies, one from Houston, Texas, one from the CDC, and one from the Netherlands. And you began to see a shift, and I'll describe why that shift occurs in just a moment. But the pneumococcus is still there, but the numbers have dropped considerably. We still see Haemophilus and a few spatterings of Staph aureus. But again, those studies that use viral PCRs began to also identify viruses as a major cause of community-acquired pneumonia. But as you can see in the bottom, the same challenge in terms of identifying an etiology. In about half or more of these cases, an etiology could not be ascertained. And then even when we looked at severe disease, which is shown on this particular slide in a study just published in Critical Care Medicine this year, a pathogen was identified in 34% of patients. And again, we're only looking at severe community-acquired pneumonias, all these patients going to the ICU. However, there was no viral PCRs performed in this study. And even with severe disease, only 10% of blood cultures were positive. And as you can see in terms of overall, Staph aureus, both MSSA and MRSA were important, and the pneumococcus has dropped down only to about 4 to 5%. And then this other study, which I want to bring everyone's attention to, looks at the possibility that what gets reported out as normal respiratory flora may in fact be a cause of community-acquired pneumonia, since we know aspiration is the most common way in which patients get pneumonia. So these investigators looked at 125 patients. They were very meticulous in their technique. They used gram stains, quantitative sputum cultures, and bacteria speciated by multi-TOF were performed. They did viral PCR on all patients, and they used a threshold. They used greater than 10 to the fifth colony-forming units per ml for a usual bacterial pathogens, that's RBP, and greater than 10%, 10 to the sixth, if it was normal respiratory flora. And what they found here is shown on this particular slide. You can see for recognized bacterial pathogens that the pneumococcus was still important, along with Haemophilus. And then if you combine that with viral etiology, you can see that a lot of these may have had co-infection with viruses. And if you look more carefully at their result, you'll notice that a recognized pathogen was present in almost half the cases, co-infection in about 12%, respiratory viruses only in about 13%, normal flora, as defined greater than 10 to the sixth, as I mentioned earlier, was found in about 17 to 8%, and they were able to decrease the number of unidentified or undetermined down to 5%. Now, one of the reasons we're seeing a reduction in pneumococcus or Streptococcus pneumoniae is shown on this particular slide. As you can see, the United States and Canada are depicted here, and you can see with the implementation of the pneumococcal vaccine, there's been a tremendous reduction of pneumococcal disease, both in adults and pediatrics in the US. It's not so much seen in Europe, that has a lower vaccine rate, as well as having greater incidence of smoking. So again, in trying to complete this section, one of the biggest challenges of diagnosing community-acquired pneumonia is, one, blood culture yields are low. Detection of contaminants actually may be higher than the actual positive blood cultures with pathogens. Often sputums are unavailable. 40+% can't produce a sputum, or they're not obtained. It's difficult to detect typical pathogens after antibiotics are started. We do have some urinary antigen tests, both for pneumococcus and for Legionella, which has improved the sensitivity, but it's still relatively low, and the results may not be changed even with the positive results. So the bottom line in this particular section is we need better diagnostic testing, also more real-time, to move from what I consider empiric therapy to more targeted therapy. Now, I want you to stay tuned for part 2, where I'll be talking about inconvenient truths.